Hello and welcome to this edition of mycyp450.org, the podcast. I'm your host, Dan J.P. Ciernia. I'm here again today with our good friend, Dr. Michael R. Gray with the Progressive Healthcare Group in Benson, Arizona. One thing I would like to just mention as we get going, these podcasts and everything we do with mycyp450.org, the purpose is to educate, inform, and empower you to improve your personal health and the health of your loved ones. The information presented in this podcast and our other digital media presentations is for your health, with a focus on genetics, lifestyle, and environmental factors. This podcast is available wherever you get your favorite podcasts, on your favorite podcast outlets. It's also available on our YouTube channel, my_CYP450, and available on our website, mycyp450.org. And again, welcome to this edition of our podcast. Dr. Gray, how are you doing today?
Doing very well. Thank you, Dan. Again, thank you for the opportunity to converse with you during the podcast and explore some of the issues that are of some significance in terms of our health.
Absolutely, and I always appreciate you being here to go over not only things related to cumulative organic chemical hypertoxicity and toxins and mycotoxins with mold exposures, but also other health considerations that we have that these conditions could be affected by or may affect other things. So in our first segment today, just let's refresh people, if first time podcast listeners and viewers, what progressive healthcare is. Talk about your two different practices, or two different clinics that you have within the practice, and then help us understand the need for not only the general practice, but with a focus on the toxicology clinic.
Progressive Healthcare Group is a 501c3 not-for-profit clinical state-licensed rural health clinic located in Benson, Arizona, which is in Cochise County, the southeasternmost county in the state of Arizona. Progressive Healthcare Group serves the San Pedro Valley Hospital District, which is basically a 30-mile radius around the city. And in my work, I do two basic aspects of clinical practice. One is an ambulatory primary care practice, and the other is a focus on the impact of toxins that are retained by my patients over their lifetime on their health. I view this as primary care as well. Others will refer to it as toxicology, and I've also suggested maybe referring to it as clinical environmental toxicology, because what I'm trying to address is the clinical impact of the environmental factors that people have to deal with, often unknowingly on a day-to-day basis in an environment that brings into their being an array of toxins that are well known for their adverse effects, both acutely in some cases and chronically. So in the toxicology practice, I've worked with people who we have been able to demonstrate are not able to clear from their bodies a portion of the toxins to which they get exposed. And the continued residence of these persistent organic pollutants then has a spin-off impact on multiple organs throughout the body, but most significantly, the nervous system, the endocrine system, creating imbalances in hormones, and the immune system, which uh, views the proteins to which these compounds attach themselves to as no longer self. They look different. And because they appear structurally different to the cells which are constantly controlling our bodies and our organs to ensure that foreign invaders don't end up resident in us, um, those cells react to these proteins as if they were foreign invaders and set off a cascade of inflammatory responses in which the white cells of the immune system are hyperstimulated and overactivated, and basically end up themselves secreting cytokines. We now have been listening and hearing a lot about cytokines because it is the cytokine storm that occurs in a small percent of patients who currently are infected with COVID-19 that ends up destroying the lungs of those patients and often causing them prolonged stays on ventilators and or dying from the complications of the cytokine storm in the lung. So over a period of years, it's been very clear that a direct result of the overload of the toxic petrochemical waste that has found its way into our bodies is triggering a slow cytokine surplus. And that cytokine surplus does have injurious effects as long as it continues. So again, we have worked with patients in our toxicology clinic now for well over 30 years to help them reduce the burden of these persistent organic pollutants and reverse the adverse effects that they have experienced as a result of their presence in their system.
And we want to take put in a fine focus on COVID in this podcast today, and that is, let's just go through some of the basics with this, and we'll look at some of the things as related to cumulative organic chemical hypertoxicity as well. But there's some really basic information that needs to be shared with our listeners and viewers regarding COVID and where we are now, where we have vaccines available, et cetera. But let's start out, Doc, with describing what COVID is and what actually happens to our bodies when we become infected.
COVID is what is referred to as an RNA virus, meaning that, some viruses are made out of DNA. In this case, this is a virus that actually is a single-stranded ribonucleic acid. COVID-19 is a part of a family of viruses known as coronaviruses because their microscopic appearance when they're looked at with an electron microscope is almost like a crown. This particular strain, to the best of our knowledge, developed in Wuhan, China. And it was first described by a young physician as being related to a respiratory disease that was being seen. And I believe this was at the end of December. He was ignored and he was belittled. And eventually it was accepted as real. And about 6 or 7 weeks later, he ended up dying from COVID. The news did travel and it was available. I think, unfortunately, at the federal level, we were not able to assemble an organized scientific response. And so we haven't, and we still haven't. And I know that sounds, smart aleck and glib on my side, but bottom line to me is that every plague that has occurred throughout history has been associated with a more and more refined practice of quarantining, of containing the infection by limiting the people who ended up contacting it. And I mean, I can say it very simply. In the United States today, if we would initiate a 14-day lockdown and really enforce it, the pandemic would end in 14 days. That is not pie in the sky. That is good public health practice. The fact that we have not done that has now cost us over 300,000 lives. And the pace at which the cases are occurring is just extraordinarily high.
Mm-hmm.
I mean, 1,500 a day, 2,000 a day, some days 3,000 new cases or new deaths, and literally thousands more of new cases. We are watching an ongoing failure in public health in this country. We can respond by articulating clearly to anybody in the government that will listen that a 2-week lockdown ends it. A 2-week lockdown, a quarantine properly done, at the moment is the only thing that will work. And although we're glad for the immunity, that's now available in the form of immunizations, it's going to take weeks to disseminate these, to get them to people so that we in fact can experience true herd immunity. But we can end this pandemic in 2 weeks if we lock down for 2 weeks. It's over.
And thus, in doing 2 weeks, we would endure 2 weeks of economic
hardship
as well.
And isolation,
yeah.
And yes.
But it's 2 weeks. We're now
right.
10 months, 11 months into this.
Yes.
And the economic impact is devastating on a personal and corporate level. I mean, it's just
absolutely. Again, that's why I keep reiterating this, that, I mean, we have not had an effective unified public health policy. When the executive officer of this country turned to all of us in February and early March and said, I'm turning it over to the governors. Well, what he's then saying is that there will be 50 different solutions. And yeah, some of them might work to some degree. Mm-hmm. But in fact, he abdicated the responsibility to offer a unified scientific approach that would have resolved this in 2 weeks. There simply isn't any question, man. And you're correct. There would be a brief moment of significant economic standstill. Mm-hmm. There's no question about that. But at the end of that 2-week period, we would be able to stand tall, walk free, and be done with this devastating virus that is costing us thousands of deaths a day. More deaths every day than occurred in Pearl Harbor. And we mobilized our nation and went to war effectively to address that problem. We can do it with COVIDs, but we really have to be disciplined. We have to think clearly and understand that a contagious disease can be stopped by eliminating contacts. And it's not just about contact tracing. Yes, that helps. But 2 weeks of quarantine would end it.
How do we, being as globally focused as every country or nearly every country in the world is right now, after that 2 weeks, how do you manage that beyond there? Say the U.S. goes into a 2-week quarantine, and we literally isolate our 300,
close our borders, do our lockdown,
Right.
And then how do we reopen?
Right, exactly. How do we get back to that international commerce world that we exist in?
I think we have to be very, very cautious. And I think we would have to do what now a number of nations have done. Um, and that is to require anybody crossing our borders, whether they're US citizens or they're not. If they're coming from somewhere else, we need to establish their status. Now, we may have testing capabilities to be able to do that literally immediately. In other words, if someone can come in and as they're waiting to go through customs, be tested and have a response and an answer, and we can know that they're negative, they're not carriers, and or they already have antibodies, then they should be free to go. But anybody that we can't confirm their status until their status is confirmed should be quarantined for at least 14 days on entry. And yes, that's a very different thing than what we've had. But the other thing we should remember is that quarantine itself comes from the word for 40 days. And the reason was that when any ship landed there, before they would let the people disembark, they kept them on the boat for 40 days, because in that time, any infectious disease would emerge, manifest, and either kill them or make them sick, and they'd be better. 40 days. That's what quarantine means.
Let's talk about now that we have vaccines available, we have two, we have Pfizer and BioNTech and Moderna that have been approved for emergency use. With the vaccines being distributed, what's the role now of how does this all work? We've got everybody needs to mask up. At least that's the recommendation. It's not a mandate, but it's a recommendation. Social distancing, washing of hands. How do those three things and the vaccines work together as we go forward? I guess the question would be, do they work together, or is it now that we've have the vaccine, well, we can do away with social distancing and masks, and we can all hug and hold hands again?
I don't believe that we can do away with any of those measures. I think we have to continue them.
With the vaccines, we've heard about allergic reactions to the vaccines. And people, they're saying people with medical histories of severe allergies should not get the vaccines right now. Describe the concerns, the medical concerns around these types of allergic reactions to this vaccine or any vaccine, but in particular this one. I mean, what is that part about?
Well, the general science of vaccination is based on the presumption that if you introduce protein material from an organism that is capable of causing serious pathology, you can stimulate the immune system to generate the same immune response that it would generate if you experienced an infection with the organism. Only you're just putting fragments of the organism or fragments of the coding proteins. But what you're attempting to do is to stimulate the immune response to develop the same level of immunity that it would if you had actually had an infection with the organism. So it's a relatively common thing for people to experience an inflammatory response around the site of the injection itself. Sometimes it can involve a portion of the limb and be, a red area that's a little bit larger and reflecting the, war that's mounting with the immune cells coming in to that area to fight the war to kill off this invading organism, which in fact is just the protein that was put there. So we're trying to mobilize that immune response. And, people's reactions to it is going to vary. I don't know, I haven't seen statistics yet that tell us exactly, with what frequency more extreme reactions occur. Um, and I would say that if people have a history of having, tendencies to allergies and are worried about it, then the strategy is to have your immunization. And in fact, anytime you get an immunization, you should wait in the doctor's office for 20 or 30 minutes to make sure that you're not going to have an immediate extreme response, which is usually when these things occur. Because if it occurs and you're in a doctor's office or you're, anywhere where there are competent medical personnel, they will have epinephrine available that can be given to block the reaction. And, again, I'm not trying to minimize it. These are real reactions. But then you do a risk-benefit analysis and you say, okay, what percentage of people who are getting COVIDs are experiencing extreme effects? And again, the data is out there. You can look it up and see it, and it's changing day to day. But, I think that the percentage of fatalities is way, way higher, and the risk is much, much greater with active COVID infections. So I am of the mind to get the vaccine. I am also likely to offer that vaccine in the office, and assuming that there are no contraindications to doing it intradermally instead of intramuscularly, I will probably be administering the majority of it intradermally. I will be checking with the companies that are manufacturing them to make sure that that's an acceptable route. But the reason that that's advantageous is because you get the same immune response with just 1/10 of a milliliter of the vaccine itself. Anybody who's had a skin test for tuberculosis has had a little bubble put on their skin where the needle is introduced between the layers of the skin, and then just 1/10 of a milliliter of the protein containing material for tuberculosis would be injected. Well, and of course it would stimulate an immune response if you had had an exposure or infection historically or actively. So in any case, similar techniques can be used for all of the flu vaccines, and it's likely that that can be done with the COVID vaccine. But as I said, I have to check with the pharmaceutical company to make sure there's no contraindication to doing that. But my own experience in my practice, where after we immunize patients, we will go back and screen to make sure that the immunity has taken or has developed at an adequate level. And in my experience in the past, the intradermal route triggered the same level of immune response as intramuscular. And the advantage is you're only using 1/10 of a cc. So again, if that's possible and it's considered appropriate, or there's no negative feedback as we make our inquiries, then when we have the vaccine, we'll offer it in that way.
One follow-on question to that, recently the UK has identified a strain of the virus that they say is 70% more infectious. Describe what that means.
That's horrendous. I mean, again, it's horrendous because we're currently living in an environment where we're not really achieving the level of quarantine that we have to stop it. But let's assume that it was 70% more infectious. The answer would still be the same. If we did a quarantine for the duration of one cycle of contagion, whether that's 10 days, 14 days, whatever the actual number is, and the infectious disease specialist should be able to tell us that already. How long does it take before a patient is no longer shedding viable virus? Whatever that time frame is, you lock down and it's done. Again, I mean, I'm horrified at the notion that we now have something else coming along. I don't know whether the other characteristics of the virus are the same. Is it causing the same level of cytokine storm in the lungs? Is the fatality rates as high as it is for COVID-19? All of that has to be looked at, but I mean, it's a terrible development, of course. That's a serious threat. And once again, I reiterate, 2-week lockdown, it's done. We just need the national will to do it. We need to care enough about the people we know are going to die if we don't arrest this pandemic to take the action that is necessary. And I don't have any colleagues in the public health community who have argued that a 2-week lockdown would not work. Mm-hmm. I just don't know why I'm not hearing them advocate for it.
How are you handling patient visits at Progressive Healthcare Group during the pandemic?
For a number of months, the building was quarantined entirely. But in recent weeks, my two co-providers, two mid-level providers that are physician's assistants, are actually seeing patients. One of the two actually has already had COVIDs and has recovered. Mm-hmm. And so that person is not at risk, and she can't put anybody else at risk. So what that means is that, basically both of the PAs returned to seeing patients. They are universally masking, even though one of the two is not really vulnerable. But as a, just a show of both solidarity and exemplifying, modeling behavior that we want to see in our patients, we're all wearing masks at the clinic.
You are practicing telemedicine.
Yes, I'm practicing telemedicine every day.
I have to mention at this point, the telemedicine aspect, especially for patients in either clinic that have a significant distance between them and you, the telemedicine aspect, I think, is a very good alternative in order to continue care at the level that needs to be, especially for somebody with like cumulative organic chemical hypertoxicity, even in regular times, but during this pandemic for sure. But I mean, it still allows patients to be able to have those consultations with you and your staff, and to be able to continue their treatment plans without any type of interruption.
And yeah, I would agree with you. I think that it has allowed us to function and address their problems and issues very effectively, even though, we're doing it by telephone.
Well, Doc, I think that wraps up the podcast for today, unless you have any final thoughts that you'd like to share.
The only thought that I want to reiterate is that 2-week lockdown would end this pandemic.
Good final thought. 2 weeks is not a long time.
No. We've already paid the price many times over.
We have. Doc, I want to thank you for being here again on this edition of mycyp450.org, the podcast. We will have many more in the future. I want everybody to remember Dr. Michael Gray practices at Progressive Healthcare Group in Benson, Arizona. He can be reached at 520-586-9111. And Doc, you're accepting new patients, is that correct?
Our practice is opened, yes.
Excellent. So feel free to, if you want to make an appointment with Dr. Gray and the staff at Progressive Healthcare Group, to reach out to them. Again, the number 520-586-9111, or there's a toll-free number, 866-586-9111. So that's toll-free 866-586-9111, local 520-586-9111. Doc, thanks again so much for being here. Stay safe, be well, and we will see you in the next mycyp450.org, the podcast.
Thank you, Dan.